So here's a laundry list alphabetically of all the frequent symptoms, complications you might see in a terminal patient on home care that you need to be prepared for. Patients with ascites can often be sent on an outpatient basis to have a paracentesis if need be. Most comfort packs or home care boxes that they send in have medications for anxiety. But depending on what the patient's diagnosis is, you can see that any one of these can be common in terminal illness.
What's interesting also, Dr. Leonard, about that is that when we prepare families to go home and patients to go home, those are part of the preparation, because if you really want a decision that's informed by patients and families, they have to know of the potential of a bleed. They have to know of the potential of a fracture and what that feels like in the home versus what it feels like in the institution. So there's an ethical issue that pervades this laundry list, because otherwise you're sending people home unprepared for the possibilities. And that's really, from our end, you know,
Right,
we're doing that all the time, I think, and not trying to figure out how not to frighten them so badly, but yet let them know that something could happen that is very traumatic, because that kind of stuff for families is amazingly traumatic. Even with preparation, it's amazingly traumatic.
I mean, you can warn them that a very sick patient may try to get out of bed and end up with a hip fracture. So, you know, and that's always my nightmare, what to do with a fracture in a patient at home who doesn't want to go to the hospital. You know, some of them can be immobilized, but, you know, depending on whether you can get somebody out there and the comfort level of the nurse with splinting or immobilizing. That's the thing I always worry about when I have, particularly an elderly patient who might have osteoporosis. I mean, I don't know what your feeling is, and I know that at least here, and I don't know whether it's an institutional difference, it doesn't seem to me that on discharge the nurses are as involved in patient education as they used to be years ago. And, you know, even in emergency settings, we'd had a system, at least at Bellevue, that the nurse would sit down with the patient, go over the medications and the instructions once more. We know that patients only get a small percentage of that on the first go-round. So, you know, I think that hospitals are so busy and there's such a nursing shortage in New York, particularly in New York City, that I think nursing education isn't the way it used to be when these situations didn't exist. So emergencies in the home, you need to assume that any patient who's terminal might get confused. Any stent that's put in can get blocked, okay, and hopefully patients have been warned about that possibility. Seizures in certain conditions, patients with the brain tumor, you want to make sure that there's a seizure pack with rectal diastat, rectal Valium, and to control seizures. Intestinal obstruction, malignant bowel obstructions can occur with tumors in the abdomen, hemorrhage for certain conditions, panic attacks, pathologic fractures, non-pathologic fractures can happen. Pleural pericardial effusions, cord compression, SVC syndrome, and urinary retention. So all of these things that are, you know, fairly routine to deal with in the hospital, a bit of a challenge to manage at home. And when you have somebody who you suspect has a superior vena cava syndrome but has an estimate of 3 to 4 weeks of life left, what do? You know, and the first thing you do is have a conversation about the goals with either the patient or the caretaker. Okay, we're going to treat any anticipated complication. So we have a comfort pack or a care box. It's called different things by different hospices that sends a small amounts of emergency supplies to the home when a patient signs up for hospice. We don't do this for our palliative care service patient. You know, it's interesting, and we don't have an agreement with a pharmacy. So again, the patients, even on palliative care service with Metropolitan Jewish, sort of at the mercy of the pharmacy that they're going to go to. And at least if they don't have these particular opiates, they'll have to order them, so there'll be a delay, and you need to anticipate that. So we want to have an immediate release opiate to treat pain and dyspnea, benzodiazepine for dyspnea, anxiety, seizures, antiemetic suppositories, such as compazine. For those of you who don't know, there's a wonderful suppository that is in the comfort pack. I think it's still there for Metropolitan Jewish. We had it for Continuum for a long time, that we call ABHR. And it has very small amounts of Ativan, Benadryl, Haldol, and Reglan. And it's really for intractable nausea and vomiting. Sometimes it really works wonders. Ativan, Benadryl, Haldol, and Reglan, ABHR. It's not available if you go to a pharmacy and ask for it, you can't get it. So it's something that's prepared specifically for the hospice, and I really wish it was on the market because it's a fantastic medication for a very intractable nausea vomiting in patients in end of life. We want to provide an anti-sialagogue for secretions and those mid-level airway secretions that patients get that they can't handle at an immediate end-of-life period. What we use is something called thiazomine, which is an old anticholinergic drug. Neuroleptics are included. We always include a bottle of Haldol, which is good not only for agitation and delirium, but for nausea vomiting through. Steroids, sometimes they're included in the pack. I noticed that Met Jewish does include some steroids, a couple of doses of steroids, which are pretty good for anything that ails you, from pain to nausea, vomiting, dyspnea, cord compression, raised intracranial pressure, and headache due to brain tumors. And finally, in some cases, I think in the regular comfort pack, there's a diuretic, there's some Lasix for CHF. We used to have subspecialty boxes as well. So a patient who is at risk for seizures or who had seizures would get a neuro box. Patients who had cardiac disease would get a cardiac pack, which might have some particular medications. And of course, there's essential equipment. Most durable medical equipment that you need to take care of a patient who's on hospice is provided by the hospice, and that's part of the agreement with Medicare, is that hospice will provide all durable medical equipment to take care of the patient. But this is the minimum that you need. So there's some patients who don't have telephones or chairs or a bedside table. We need to consider the culture, particularly in the United States. Multiculturalism is flourishing. Awareness and sensitivity to cultural differences is needed. There are many families with extended families in the mix, and having a family meeting becomes even more complicated. If you practice in Brooklyn, if you go 2 blocks in either direction, you'll hit a different cultural group. And that's what it is. It's collections of small, and to Queens to some extent also. So we have to deal with language barriers. We cannot always dispatch an interpreter on our home care visit. So we rely very much on the language line, which of course in talking about these sort of issues that you talk about at end of life can be really difficult and loose in the translation, if you will. We have to respect family traditions and religious beliefs. Certain cultures have certain beliefs about death, as well as pain and symptom management. So we say, well, it'll cost less money if we take care of patients at home. Certainly it costs less for the third-party payers, but that cost is generally given to the patient. It actually does result in increased cost to the patient. So for a caretaker who's caring for a patient who has 4 months to live and needs somebody in the home all the time, there's the cost of lost wages. If they're not on hospice, there may be medications that are not covered. And then there's always custodial care. You can't have one person taking care of a patient 24/7. So there's always custodial care. And some of you may know that hospice provides about 20 hours a week of a home health aide if the nurse judges that it's needed. Okay, so 4 hours a day isn't a whole lot if you're the only family member taking care of a patient. We know that the population of patients with multiple medical illnesses are steadily aging, more than 65 years. Elderly patients cared for at home have special needs, and remember, the caretaker may be elderly also. And so 4 hours a day, again, may not be enough. Children, most of the literature on home care is focused on adult patients. Maybe we'll do something with children. Home care of the ill child is very demanding. Not that it isn't with adults, but parents of pediatric cancer patients are still reporting that child's pain is inadequately treated at home. And that's from the Institute of Medicine report from 2003. And there's inadequate assessment and treatment of pediatric pain is consistent with what's been in the literature. Okay, what about outcomes? We evaluate the outcome of home care. Did we give a good experience by the effects on the family, particularly following the death? This was a study that was in JAMA in 2004. And in the year 2000, there were, I think, about 2 million deaths in the United States. They looked at more than 1,500 decedents. And they did a mortality follow-back survey of family members who took care of the patient in the last place of care. And what they wanted to know is, did healthcare workers provide physical comfort and emotional support for the patient? Was there support for shared decision-making on the part of the agency or taking care of the patient? Was the dying patient treated respectfully? And did the service attend to the emotional needs of the family and provide coordinated care? So, of the 1,578 decedents they looked at, 32.9% died at home, or 510 patients. Of those 519 patients who died at home, 198 did not receive any nursing services, and 49% of those had home hospice. Okay. 25% reported inadequate treatment for pain or dyspnea. 25% reported concerns, again, with MD communication. And 33% reported insufficient emotional support if from their home health agency, the hospital, or the nursing home. But only 20% reported that if they were on hospice.